Welcome, everyone. My name is Cindy Lowen. I'm a Medical Affairs Manager with Nestle Health Science, and I'm thrilled to introduce today's speaker and moderate our Q&A session for the presentation entitled Optimizing Nutrition in the ICU, Addressing Challenges for Better Patient Outcomes. I'm delighted to introduce today's speaker, Dr. Doug Nguyen. Dr. Nguyen is a distinguished gastroenterologist serving as Professor of Medicine and Director of the Inflammatory Bowel Disease Program at Loma Linda University Medical Center. Notably, he has successfully completed the Clinical Nutrition Fellowship for Physicians offered by Nestle Nutrition Institute, further enhancing his expertise in the field of nutrition. With an impressive portfolio of over 150 peer-reviewed publications, Dr. Nguyen is recognized for his significant contributions to the field of medicine. Moreover, he is a sought-after lecturer, sharing his knowledge and insights at numerous national and international conferences. We are privileged to have Dr. Nguyen join us today as our esteemed speaker. Please welcome Dr. Nguyen.
Great. Thank you, Cindy. Thank you, everyone, and good morning to the people in the West Coast and good afternoon to the people in the East Coast. Thank you so much for joining us today on going over a very important topic on how do we optimize nutrition in the ICU setting, looking at some of the challenges that we typically face and how we can actually improve our patient and better their outcomes. So here are my disclosure for the various companies that I've worked with in the past. And here's today's program objective. So hopefully as you come away from this program, you'll be able to address some of these specific objectives. The first is to define enteral feeding intolerance in the hospitalized critically ill patient and examine how this may affect their clinical outcomes, particularly associated with feeding intolerance. The second objective is to discuss various management strategies to help improve both gastrointestinal and metabolic intolerance and how to optimize the delivery of enteral nutrition for our patient in the ICU setting. And then lastly, we'll also discuss data identifying strategies that we can improve nutritional delivery in the ICU. And I'll also kind of summarize and bring it back with our latest publication, looking at how we're doing in the real world setting with some of these studies and some of these research and how we're really applying it from a clinical practice standpoint and how we're doing sort of in the US from that standpoint as well. So this leads me to my first poll question. What percentage of your current practice is in the ICU setting? So if you can open the poll for the audience. So it looks like the poll has closed, and we have a really good mix of ICU practitioners today. So we have anywhere, it's sort of evenly split across the different, the four categories, but the vast majority of the attendees today seem to be to have a very high, high focus in the ICU setting. It adds up to about 30, 40, 46% of the attendees today have at least 50% of their current practice in the ICU setting. So I'm excited to hear about your experience at the end of the program as well regarding enteral nutrition in the ICU. But I wanted to highlight a case to start off and kind of walk you through this entire patient case and kind of the literature and the research surrounding this particular sample patient. So this is my ICU patient, a 46-year-old female with a BMI of 44, admitted to the ICU with severe COVID-19 pneumonia with acute respiratory distress syndrome. The patient's past medical history includes the following: insulin-dependent diabetes, history of obstructive sleep apnea, asthma, hyperlipidemia, coronary artery disease, and the other one is chronic kidney disease as well. The patient's current status is that they are currently on active oral medication as well as an off-label use of an immunotherapy to help treat the COVID-19 infection. The patient was hypotensive on arrival to the ICU. So for blood pressure support, the patient was placed on norepinephrine and is currently being mechanically ventilated related to the ARDS, or acute respiratory syndrome. And the patient's currently getting both Versed and fentanyl infusion as part of that mechanical ventilation protocol. The patient is receiving 2 feeds via a nasal gastric tube with polymeric formula starting at 30 ml per hour. And there's some difficulty that the clinicians has noted with titration of the feeds due to high gastric volume, as well as visible abdominal distension. And the patient also has approximately 6 watery bowel movement per day on this particular feeding regimen. The patient also has some difficulty with glycemic control, with most of the blood sugar being consistently elevated above 500, and is also placed on an insulin infusion. And as you know, right, patients who develop hyperglycemia in the ICU setting have a worser outcome. So it's really important that we get that hyperglycemia under control. So the clinician placed the patient on a continuous insulin infusion. So when you look at sort of enteral feeding intolerance, it's really important that we define what is it? What is this enteral feeding intolerance? So for me, when I think about enteral feeding intolerance, or EFI, which we'll use throughout the program today for enteral feeding intolerance, there are a couple of aspects that you should think about. The first is traditionally defined in the literature as large gastric residual volume. And there's really no uniform definition for this in the literature. And so when you do a literature search, you'll see that typically it's defined as having both visible abdominal distension with elevated gastric residual volume. And that volume is defined anywhere between 500 to 1,000 cc. The other definition of enteral feeding intolerance in the literature is something very simple. It's a clinical definition, which is the presence of GI symptoms. So patients who have visible abdominal distension, patients who develop significant diarrhea, as in the case of our patient, any nausea, vomiting, increase of intra-abdominal pressure, or presence of ileus, those can also indicate enteral feeding intolerance. Another bucket in enteral feeding intolerance is the inability to adequately deliver enteral nutrition, right? So they can't get to their caloric or protein needs because of enteral feeding intolerance, and that could be both from a metabolic standpoint, from a critical illness standpoint. And then lastly, this sort of newer concept of metabolic intolerance. So many of our patients in the ICU setting, as you know, are obese with multiple medical comorbidity. As highlighted here in a recent study, it was estimated that about 50% of our patients actually meet the overweight or obese category in the ICU. So many of these patients have underlying comorbidity that makes them have underlying metabolic intolerance. And that's, of course, worsened by critical illness as well. And so you can see here that they do develop hyperglycemia as well as decreased insulin sensitivity, as in the case of our patient with presenting with hyperglycemia. So these are sort of the many different buckets that I think about when I think of defining enteral feeding intolerance. So clinical symptoms, right? Large gastric residual volume, inability to deliver adequate caloric or protein needs, as well as this concept of metabolic intolerance with hyperglycemia and decreased insulin sensitivity. So what's the prevalence of enteral feeding intolerance, and what is its clinical impact in the ICU setting? Once we've defined enteral, feeding intolerance, what its clinical impact? So using those same definition, you can see here. So why do patients develop gut failure in critical illness? There's several issues that occur, right? The first is this whole idea of visceral hyperperfusion, because the patient's septic, the patient's hypotensive, and because of this visceral hyperperfusion, the patient develops a lot of inflammatory cytokine, which can cause leakiness in the gut. And because of this ischemia and reperfusion injury related to the fluids that we give the patient, the inotropic to help bring up the blood pressure, the patient develop gut ischemia and reperfusion injury. And because of this, they can actually develop the loss of gut barrier function, leading to translocation of bacteria and endotoxin across the mucosal area, causing more GI intolerance. And you can also see here that as a result of that, there's a high release of inflammatory and cytokines and chemokines as well, that results from multi-organ dysfunction as well as the systemic inflammatory response syndrome, or SIRS, that lead to this overall gut failure and failure in the digestive tract and the ability for the patient to assimilate nutrients. So when I think also of enteral feeding intolerance, it actually may involve multiple areas of the gut. It's not just the stomach with a high gastric residual volume, right? Where patients can develop, gastroparesis or delayed gastric emptying related to critical illness. They can have nausea, vomiting, elevated blood glucose, things like that, which, typically occurs within the stomach. And but it also can occur within the small gut as well as the pancreas and the biliary tree as well, resulting in malabsorption, intestinal edema, dysmotility, things like that. And patients can also have, enterocutaneous fistula, particularly in that ICU setting with a patient who had prior surgery. And now because they have wound breakdown, they can develop enterocutaneous fistula. So that can also lead to enteral feeding intolerance. And of course, it can also involve the colon, right? From ileus, from Ogilvie syndrome, where they actually have gut dysmotility related to that dysfunction in the enteric lining of the colon as well. And you can also see here altered biome. When you're sick and you're putting patients on different antimicrobials, you're also disrupting the patient's overall microbiome, which can also lead to feeding intolerance and impaired gut assimilation of nutrients. So my next poll question to everyone is, what percentage of your ICU patient experience enteral feeding intolerance? Okay, so the poll question came in, and it looks like the vast majority, but almost half of the attendees today report that the feeding intolerance that they see in their clinical practice ranges anywhere between 26 up to 50%. And this is also very in line with kind of what the literature shows as well. So I'm going to bring up this next slide. So there was a huge paper that was published in JPEN in 2015. It's a retrospective study indexing about 2,000 mechanically ventilated patients across 167 ICUs. So it's mixed ICU, both surgical and medical, from 21 different countries. And you can see here that the feeding intolerance was defined as approximately about 30-something% in the ICU. So 1 in 3 ICU patients typically experience this. And you can see here that when patients develop feeding intolerance, it was actually a marker of actually clinical outcomes. So you can see here that patients who develop feeding intolerance actually have more days on the ventilator. They have longer length of stay in the ICU. And even when you follow those patients out for the next 60 days, it's associated with higher risk for mortality as well as survival. And this is also noting that in both groups, right, for both the feeding intolerance and the feeding tolerant patients, you can see here that their overall Apache score, which measures disease severity in the ICU, were very comparable. But feeding intolerance in and of itself seems to be this marker of sort of worser clinical outcomes for these patients. So longer ventilator, longer days on the vent, longer ICU stay, as well as associated higher rates of 60-day mortality and days to discharge alive as well. So longer length of stay in the hospital as well. So again, it's really important that based on this study, it really highlights the fact that we really need to do what we can to promote better feeding tolerance, if you will, because it does seem to affect their clinical outcome. And very much like that particular literature indexing almost 2,000 patients, in this particular review paper and meta-analysis, you can see here, looking at 31 studies indexing over 4,000 patients, you can see here that pool proportion of feeding intolerance also is about 1 in 3 ICU patients as well, based on the definitions here of inability to deliver adequate amount of EN, large gastric residual volume, GI symptoms, things like that. So you can see here that 1 in 3 ICU patients, so very consistent with what you're observing in your own clinical practice, that 1 in 3 patients in the ICU setting will, develop feeding intolerance. And that feeding intolerance is an independent marker of basically not only disease severity, but also the patient's overall outcome and mortality out to 60 days. So this is why it's so important that to really, really address the feeding intolerance very early on arrival to the ICU, because hopefully by addressing it early, we can kind of reverse that overall outcome for patients. And you can see here, here's another study highlighting, looking at various studies highlighting the impact of enteral feeding intolerance, or EFI, on clinical outcome. And some of these are prospective and retrospective studies. You can see here that the rate of feeding intolerance is exactly what you guys are all observing in clinical practice, ranging anywhere between 25 up to 50% in clinical practice. And all of these studies clearly demonstrate worser clinical outcome when you look at patients who develop enteral feeding intolerance. So increased ICU mortality, increased ICU length of stay, higher, hyperglycemia. And what was really interesting is in this 2008 study, it not only showed increased mortality at 30 days, but also 90 days out in patients who develop feeding intolerance. And you can also see in this 2011 study, it was also shown that patients who develop enteral feeding intolerance also developed this higher risk for bacterial translocation and bacteremia, which also was associated with increased ICU mortality as well. So you can see here that if you had a single clinical marker that you can use to predict ICU outcome from a nutrition standpoint, it's really going to be that enteral feeding intolerance. And again, if we can reverse that, hopefully we can actually improve the patient's overall outcome. And when you look specifically at our patient, so this is a patient who has COVID-19 and specifically looking at feeding intolerance during the COVID-19 era, you can also see here patients who have feeding intolerant versus no feeding intolerance was associated with a longer length of ICU stay, longer days on the ventilator by almost a week in the group that developed feeding intolerance compared to the no feeding intolerance group. And you can also see here that there was also approximately 1 week longer length of stay in the hospital in that feeding intolerance group compared to the non-intolerance group. And you can see here as well that the in-hospital mortality in patients who has COVID-19 infection and hospitalized in the ICU, you are 2 times more likely to die in the hospital if you develop feeding intolerance versus no feeding intolerance. So very comparable to what we're seeing in other ICU states as well for our patient. So if you go back to our patient here, our patient that I highlighted earlier have multiple factors, right? Clinical factors that show that they develop that the patient has EFI. So the first is abdominal distension. The second is high gastric residual volume, right? Greater than 500. The patient developed persistent hyperglycemia requiring an insulin infusion, as well as significant diarrhea on the polymeric formula, even at only 30 cc's per hour. So are there potential tools for predicting feeding intolerance so that we basically can jump ahead of the curve and trying to get the patient to have better tolerance? So here are some tools that I want to kind of highlight that we can use in clinical practice, that we may consider in clinical practice to actually help predict EFI, and perhaps starting patients on specialized formula that could actually improve their risk for enteral feeding intolerance. So clinical factors that we use are, patients with diabetes, patients with previous abdominal surgeries, patients in the burn unit, patients with acute on chronic pancreatitis, patients with spinal cord injuries, patients with shock, patients who present with significant electrolyte disorders like our patient with chronic kidney disease, patients who require things that may slow down the gut like fentanyl, right, as part of their sedatives. Things like opioid and vasopressor can also cause a gut dysfunction as well, and reperfusion injury that may also affect enteral feeding intolerance. And then patients who have existing medical comorbidities like heart disease, cancer, inflammatory bowel disease, these are all important factors to keep in mind, that these are the patients who are probably at the highest risk for developing enteral feeding intolerance. So these are the group of patients that you might want to consider earlier intervention with more specialized formulas that may help promote better enteral feeding tolerance. Of course, gastric residual volume is used very widely, even in our own ICU setting here at Loma Linda. And you can see here, it's also been evaluated in many studies as well. And there's really no consistent relationship, even though we use it quite a bit in clinical practice, between aspiration risk and gastric residual volume. And it's very variable and very operator dependent, depending on how you're aspirating out that gastric fluid volume. So you can see here that the Aspen Safe Practice for Enteral Nutrition guidelines really say that, gastric residual measurement can range anywhere between 250 to 500. And at that, if you get that value, you should consider to take actions to reduce the risk of aspiration. And if you consistently have a gastric residual volume less than 500, this should not automatically result in withholding enteral nutrition unless there's other signs of feeding intolerance that might be present. So that's something to keep in mind, that don't rely solely on gastric residual volume to sort of label someone as having enteral feeding intolerance. Really use it in addition to other clinical parameters as well. There's one study that was really interesting that basically looked at three parameters to predict feeding intolerance. So the presence of abdominal distension or pain, the presence of nausea, vomiting, and diarrhea. And when you combine these 3 clinical factors together, if the patient, and each one goes from 0 to 3 on the scale, and if you have a scale that's greater than 5, that's someone who's going to who's developing feeding intolerance. And you can see here that again, in that patient who had that higher scale on this feeding intolerance index, there was a very high risk associated with mortality. So in our practice, anyone with a scale greater than 3, we would define that as feeding intolerance. And this is someone that, again, we need to make very rapid intervention from a nutritional standpoint to reverse that feeding intolerance. Another scale that's been espoused in the past has been actually, widely used in the past is this whole idea of malabsorption index. When you have a patient that's in the ICU, you can quickly do this checkbox to actually assess their risk for malnutrition index, and it looks at various clinical parameters such as the patient's nutritional status, medications that they're on, their stool frequency, their serum albumin, their current medical diagnosis, things like that. And many of these things can also help highlight a patient who's at risk for malabsorption, and therefore we should consider, again, more specialized formula, more intervention to hopefully prevent the onset of EFI for these patients. So these are some of the different tools that you could consider utilizing, including the feeding intolerance index, in combination with the gastric residual volume, in addition to the patient's history, and of course the malabsorption index, to hopefully help you sort of define feeding intolerance early on in the patient's ICU stay so that you can make the intervention early to improve their overall outcome. So this particular patient, the patient that I highlighted earlier, has multiple clinical risk factors for EFI, right, including diabetes, obesity, the patient's on opioid fentanyl because the patient's on mechanical ventilation, and of course the patient's in septic shock. So many of these clinical parameters alone already indicate that this patient's at extremely high risk for feeding intolerance. So when you look at sort of the Aspen recent update to nutrition support in the critical care setting, I'm going to highlight both the guidelines from 2016 to 2021 and seeing how this kind of differs between the two sort of recommendations. So the first is in 2016, you can see here for those in high nutritional risk, it's important to achieve at least 80% of their caloric needs within the first 48 to 72 hours. Since then, we've had many more studies that, in that first 3 days of the ICU setting, perhaps it's better to target at a lower number, so to permissively underfeed the patient and then escalate the feeds as the patient clinically improve from their sepsis. So you can see here in 2021, it's reflected in their guidelines that really, regardless of the overall nutritional risk, you should consider sort of a starting point anywhere between 12 to 25 kcal per kilogram. And again, we typically grade that over that first 3 day, and on that 4th day, as the patient continues to improve from their critical illness, that's when we start really titrating upward the enteral feeds. The second is the protein need from 2016, low evidence, but really to push for that 1.2 to 2.0 gram per kilogram per day of nutritional need for protein need. And you can see here that remains unchanged in 2021. The 2016 guideline recommend EN over PN use. And really, it's recommended that PN should be withheld for the first 7 days in patients who are at low nutritional risk. In 2021, there are some recent studies to show that the outcome for both EN and PN are relatively comparable with how we do PN currently. And so the recommendations to consider both modality equally, regardless of overall nutritional needs. I think this is a little bit of a miss because there's just so much literature on cost savings for EN. There's so much literature on the additional clinical benefits of EN relative to PN, not just length of ICU stay and mortality, but really other clinical benefits such as, reduction in bacteremia, things like that as well. The other recommendation regarding supplemental PN, you can see here in 2016, it was recommended to hold off on PN for that first 7 to 10 days. In the new updated guidelines, again, it's not necessary to do so. You can see here also additional recommendations regarding mixed lipid in the updated guideline. Fish oil or soy base can also be used in patients. So again, some updates in the guideline kind of help us sort of best tailor our enteral nutrition feeding protocol in our ICU patient setting. But you can also see here, I think the 2021 guideline from Aspen really kind of doesn't completely reflect some of the nutritional as well as non-nutritional benefit of EN. And there's such a large body of literature on this, right? Because we know that it's really important to feed the gut. And so from a cost saving standpoint, we know that EN is much cheaper to initiate than PN. So in our clinical practice, this is something that we still utilize much more heavily than PM. But you can see here that here are some additional benefit from EN, right? We know that it helps improve muscle function and mobility and helps patients return to baseline function. We also know that it provides a good variety of micro and macronutrients. It helps maintain that lean body mass for a patient. It also helps promote improved mitochondrial dysfunction, so that battery, the energy cells of our body. And we know that it also helps with protein synthesis as well as help patients meet their overall metabolic demand. We also know that EN has very significant benefit based on several studies, reducing that overall SIRS response, protecting the gut by modulating adhesion molecule to really decrease that translocation of bacterial toxins across the mucosa. We also know that various formulas, particularly EN formula, can also improve gut function long term by improving absorptive capacity. And we also know that early EN in several studies can also promote reduction in ICU-related infectious complication, as well as potentially length of stay in the ICU as well. So again, these are the many nutritional and non-nutritional clinical benefit that we need to consider when it comes to EN and think about when it comes to EN. So what are some additional strategies that we can consider to help reduce feeding intolerance? Okay, so you can see here when I think of strategies, the first bucket is, of course, pharmacologic intervention. So patients who develop diarrhea, we may consider antidiarrheal or fiber supplementation with their formula. Patients who develop gastroparesis or delayed gastric emptying, we can consider prokinetic agents. As the patient gets better, we may also consider minimizing sedative as well as analgesics that may affect gut emptying and things, using various things like Precedex, right, to help, which has less gut effect, if you will, in terms of delayed gastric emptying. We also may consider opioid antagonists for patients who develop like Ogilvy's or ileus with low-dose naloxone or metronidazole, and we do that very commonly in our ICU setting as well. So in addition to pharmacologic intervention, patients who develop enteral feeding intolerance, you may also want to consider tube position. So in this particular study, looking at patients' tube position and whether or not it affects enteral nutrition outcomes. So in our own clinical practice, it's very easy to place that nasogastric tube or oral gastric tube, right? But if the patient does develop feeding intolerance in this particular study, you can see here that by just advancing the tube into that nasojejunal position, right, to extending that tube into the nasojejunal position, you can basically very dramatically reduce the incidence of feeding intolerance by almost 70%, because at the end of the study, only 13 versus 31% of the patient developed feeding intolerant after the tube was advanced to into the jejunal position. So again, the tube placement may matter in selected patients as well. So that's another strategy that you can consider to help promote better tolerance. If you go back to our patient, the patient did have the nasogastric tube, and then subsequently we advanced the tube into the jejunal position. We did start her on metoclopramide to help improve gastric emptying, which did lower her gastric residual volume, but she persistently had diarrhea and hyperglycemia. So despite our intervention, she still has diarrhea and ongoing hyperglycemia based on her current tube feeding protocol in the nasojejunal position. So if you sort of look at different feeding protocols. So there's several that's been published in the literature. I'm going to highlight one of the studies, but you can see here, this is an older study, but it looks at what we call the PEP-UP protocol. So basically in this particular study, what they did was, because it's hard to reliably predict, even though we have all these different markers of who may develop enteral feeding intolerance. In this particular study, they randomized the patient using either the PEP-UP protocol, which is a volume-based protocol, where they started the patient with a semi-elemental formula, and they started the patient on motility agents, right, to help promote better gastric emptying. And they basically compare that to routine care. You can see here the group that was placed on the specialized protocol, feeding protocol. In this case, it's volume-based. You can see here that their they're much more likely to start on EN faster than the group in the control group. They're also able to deliver more calories as well as more protein in that group that is on the specialized feeding protocol compared to the control group. So when you're looking at your different practices, it's really important to sort of look back and see how we can potentially initiate some of these specialized feeding protocol based on your local resources, and because it can, promote better sort of nutrient delivery for our patient. Here's another study published by the Mayo Clinic group looking at their home enteral nutrition program. And this is an enteral, a retrospective study, and they wanted to compare basically a peptide-based formula compared to the standard formula. And you can see here across all of the different parameters. You can see here by switching the patient from a standard formula to a peptide-based formula, you can see here there's dramatic reduction in nausea, vomiting by 50%, also dramatic reduction in diarrhea. When you make that switch to a peptide-based formula, also reduction in abdominal pain, cramping, abdominal distension, and patients who report no ongoing GI symptoms is also dramatically improved, 133% in the group that was switched from a standard formula to peptide-based formula. So you can see here that formula selection may also seem to matter and may also seem to help with promoting better tolerance for our patient. And you can also see here in this particular study, this is a home enteral nutrition patient group, but you can see here that the healthcare resource utilization, when you switch a patient from a standard formula who develop intolerance to a peptide-based formula, you can also see here that you're getting less phone calls, less ER visits, and less unscheduled visits with their provider when the patient was on a peptide-based formula compared to a standard formula. So even if you started off with a standard formula, when the patient do develop an enteral feeding intolerance, you could consider, switching to a peptide-based formula, because this seems to promote better tolerance in many different clinical parameters, from diarrhea to nausea, vomiting, as well as abdominal distension as well. So this is really kind of important to see that we can make that switch for our patient if they do develop enteral feeding intolerance. So we've highlighted a couple of strategies in which you can help promote better enteral feeding tolerance, one of which is formula switch, right? One of which is considered a specialized protocol, one of which is considered pharmacologic intervention with various medications. Here's another study that also highlights that the formula that we pick may also affect feeding tolerance as well. So in this particular study, where patients receive a high protein, low carbohydrate, 100% hydrolyzed whey protein tube feeding formula compared to a standard polymeric formula, you can see here that, again, in this intention to treat analysis, we saw that there's a very dramatic reduction in need for insulin, as well as average blood glucose in the group that received this 100% hydrolyzed whey protein, low carbohydrate, high protein formula relative to the polymeric formula. So again, that changing that formula around seems to also affect metabolic tolerance and insulin sensitivity, as highlighted in this particular study as well. So back to our patient, you can see here that finally the decision was made on day 3 to change the formula to 100% hydrolyzed whey protein. The patient is obese, so the clinician at that time decided to pick a very high protein, low carbohydrate formulation. And because of that formulation switch, the patient's diarrhea improved. The patient didn't develop any significant bloating. The gastric residual volume decreased very dramatically, and the enteral feed was able to be advanced. And not only that, the patient's requirement for insulin also dramatically reduced. And after 2 prolonged weeks of stay in the ICU, the patient was able to be extubated and then subsequently transferred to the medical telemetry floor. So you can see here, by making some of these intervention, we advanced the tube. We started the patient on a prokinetic agent. We changed the formula. The patient did have improvement in their feeding tolerance. So my next poll question is, what is the most preferred modality in your own practice for improving enteral feeding tolerance? Okay, so most of the audience, almost 7 out of 10 of the participant today picked specialized formula. So making that switch to the like a peptide-based formula to help promote better tolerance. So that's really interesting. So this leads to, I want to kind of brag a little bit and kind of share with you our recent publication on how we're doing. So we kind of highlighted a lot of different principles regarding enteral feeding tolerance and intolerance and strategies in which we can improve feeding tolerance for our patient in the ICU setting. But when you sort of think about all of this science behind, enteral feeding intolerance, are we really applying these principles in clinical practice? So I want to highlight here a study of hot off the press, right? We recently published this particular study. Really, it's a retrospective cross-sectional study using real-world data from the Premier database. So you can see here, we index over almost 20,000 patients across 67 different hospitals to really see how we're doing in clinical practice. And you can see the spread here. So this is the summary of the study. But basically, you can see the spread here that most patients did receive the standard intact protein formula, about 13,000 patients in our population of almost 20,000 patients. And then it was evenly split between the 100% hydrolyzed whey peptide-based formula versus other peptide-based formula across the ICU. And you can see here that the median ICU length of stay in this particular study cohort was 8 days. The median age was 66 years old, and the median length of hospitalization was about 14 days. So this is kind of what we're observing in the real world setting in this particular retrospective cross-sectional study. And I'll highlight the specific of the study in the next subsequent slide. So what we also learned from the study is we wanted to look at pattern of enteral formula usage, right? Because you can see here it's spread basically across the 100% hydrolyzed whey protein versus other peptide-based formula versus the standard polymeric formula. So when we did this particular study, we recognized that what the pattern that we recognized was that the patient who were most likely to receive a peptide-based or 100% hydrolyzed whey protein formula was the patient who were the absolute sickest with the highest level of medical comorbidity prior to their ICU stay, whereas the polymeric formula was reserved for patients who were quote unquote less sick in the ICU. So we are applying what you are reporting in your survey, right? In that survey that we conducted, that yes, we are utilizing in the real world setting across almost 20,000 patients that clinicians have this higher propensity to pick the 100% hydrolyzed whey protein relative to other formula for the sickest patient, for the patient with the highest disease severity, for the patient who were the most septic, who needed, IV steroids and the use of propofol, things like that, and basically reserving the polymeric formula for the less sick ICU patients. So this is, again, very in line with what we're doing in clinical practice, very in line with the literature that in those sickest of patients who may develop enteral feeding intolerance, we want to consider that 100% hydrolyzed whey formula relative to the polymeric formula. And so are there are differences in the peptide-based formula, right? Is there a difference between the 100% hydrolyzed whey protein versus a mixed formula with some whey and some casein, right? So you can see here that when we look at the clinical effect of the 100% hydrolyzed whey protein and its effect on enteral feeding intolerance across this almost 20,000 patient population, you can see here that even though the patient who received the peptide base and the 100% hydrolyzed whey peptide, that those two groups were much more like sick, if you will, relative to the polymeric formula. You can see here that across all of our measured parameter using the ICD-10 coding for GI intolerance, for hypoglycemia, for need for rectal tube, right, for diarrhea, you can see here that the group that receive 100% hydrolyzed whey protein, even though they tend to be a lot sicker than the other two patient population, the other two groups, you can see here, we saw a much lower rate of GI intolerance, a much lower rate of hyperglycemia, right? And a much lower rate of need for a rectal tube in the group that received the 100% hydrolyzed whey protein relative to other peptide-based formula and standard intact protein. So you can see here that the formulas that we pick seem to also affect feeding intolerance as well, even though these patients are, again, the sickest of the sick patients in the ICU. What was also interesting was when we look at discharge diagnosis. So when we talk about maybe there's certain formulas may promote better feeding, better nutrient assimilation, better metabolic tolerance, you can see here that the risk for malnutrition as well as significant weight loss diagnoses at time of discharge was also much lower in the group that received 100% hydrolyzed whey protein relative to other peptide-based formula and as well as polymeric formula. Again, we're seeing that, right, based on the previous studies that I've shown you, that there's something about this 100% hydrolyzed whey protein that helps maybe promote better nutrient assimilation relative to other formula. And this is also clearly seen in this large database study as well. So again, when the patient's hospitalized, we see improved GI tolerance. We see less rates of hyperglycemia, less need for rectal tube in the group that receive 100% hydrolyzed whey peptide versus other peptide formula, and of course compared to polymeric, right? But what's also really interesting is when you follow the patient long-term throughout their hospitalization course and their risk for malnutrition and weight loss, we also see a much lower rate of malnutrition and weight loss diagnoses in the group that receive 100% hydrolyzed whey protein relative to other peptide formula and the polymeric formula as well. So again, this is really in line with all of the literature that we've shown that really we're observing this in the real world setting, that there is certain formulas that may promote better GI tolerance, as well as metabolic tolerance, as well as better nutrient assimilation as well, based on this particular finding. And of course, in this particular study, we also, I wanted to show you sort of what the overall risk is when you pick other formula relative to the 100% hydrolyzed whey formula. As you can see here, for GI intolerance in this particular data set, you can see here, if you were to pick a peptide-based formula relative to that 100% hydrolyzed whey protein, your 18% higher rate of observing TI intolerance in that other peptide group and 15% higher in the standard intact protein compared to the 100% hydrolyzed whey formula. And remember, the sickest patients were getting the 100% hydrolyzed whey formula. So even with that disease severity, we're still seeing that the 100% hydrolyzed whey formula seems to promote much better GI tolerance compared to other peptide-based and standard intact protein, right? By 18%, by 15. And that is, of course, statistically significant. And that, when we talk about metabolic tolerance as well, you can see here, the risk of hyperglycemia was much lower in the group that received the 100% hydrolyzed whey protein compared to other peptide-based protein, almost 80% lower rate, right? And this is very statistically significant, even when you're applying it to this very sick patient population who has underlying medical comorbidities prior to their ICU stay. So the other thing is we also wanted to look at healthcare resource utilization between the 100% hydrolyzed whey peptide versus other peptide-based formula, right? Because these are the sort of the sickest group of patients, and we wanted to compare the two subgroups that were the sickest. And you can see here that if you were to pick the 100% hydrolyzed whey protein, the overall length of stay were very comparable between the two groups, and the ICU length of stay were also comparable between the two groups. The inpatient mortality was slightly lower in that 100% hydrolyzed whey population. But what was really interesting was when we look at the mortality on readmission, you can see here that the mortality in that group who were rehospitalized subsequently was substantially lower in that 100% hydrolyzed whey protein group compared to other peptide groups. So again, that formula selection seems to have very significant impact on the patient's overall outcome, not only in the short term, but appears to be in the long term, even in that very sick group of patients who needed a peptide-based formula. So overall, here's a summary of the US trends for enteral nutrition in the ICU. You can see here that the observed trend is that if you have the highest disease severity, clinicians tend to favor the 100% hydrolyzed whey peptide formula relative to other formula. If you have more medical comorbidities prior to that ICU admission, clinicians are also tending to pick that 100% hydrolyzed whey protein relative to other formula. And overall, in the overall patient population of almost 20,000 patients, we saw that the whey the 100% hydrolyzed whey peptide has lower incidence of GI intolerance. In fact, it was 18% higher in the peptide-based group, other peptide-based group, and then 15% higher in the standard intact protein group. And what was really interesting is when we look at that special formulation, that very high protein, low carbohydrate formulation, we can see here that when you compare that the 100% hydrolyzed whey protein formula relative to the peptide-based formula, there was an 80% lower rate, basically, of incidence of a clinically significant hyperglycemia in the other peptide group relative to whey protein. And we also saw lower rates of malnutrition as well as weight loss on discharge in the 100% hydrolyzed whey protein formula relative to standard peptide and other formula. In fact, for malnutrition, you can see here 30% lower in the whey protein group relative to peptide, and then of course 15% lower in the whey protein group relative to intact protein. So even in that group of patients who's less sick, who's on polymeric formula, we still see the clinical benefit of whey protein for malnutrition as well as weight loss in that group of patient as well. So this leads me to my final slide and my take-home point. So EFI presentation can be very diverse, and it can range anywhere from GI to metabolic intolerances in the ICU setting. We've highlighted several strategies in practice that you can use to help reduce EFI, including pharmacologic, consider the different tube position, tailoring your feeding protocol based on your local resources, and then of course formula selection. We highlighted here that even in the real world setting, that the 100% hydrolyzed whey protein seems to confer much more clinical benefit from a GI and metabolic intolerance standpoint relative to other formulas. And then the last point is that predictors of EFI are not always consistently reliable. And so in many cases in my own practice, I always consider 100% hydrolyzed whey formula up front in that first 3 to 5 days of hospitalization or in the ICU, and then transition as they develop more tolerance to a polymeric formula. And of course, this is supported by the real world setting and by our study to show that perhaps that strategy may be cost savings in both the short term and long term as well.